Hello, and welcome to this episode of In Discussion With from Pharmacy Update Online. Today I'm talking to Deborah Evans about GLP-1 receptor agonists, that is, the fat jabs, and what we have learned over the past 12 to 18 months. Deborah, we've spoken before, but all the same, could you start by introducing yourself?
My name is Deborah Evans. I've been a pharmacist for almost 40 years. I run a private clinic and pharmacy in Winchester in Hampshire, which is now 3 years old. We offer a wide range of services, and my particular passion and speciality includes women's hormonal health, perimenopause, menopause, contraception, and more recently, weight management.
And can you give us a brief overview of your role, what your current job involves?
So my role covers a wide range of activities, as you can imagine. As an independent business owner, I lead and manage my team, run all the finance and support the operational processes within the organization. I'm also superintendent pharmacist and take a role as clinical director. But importantly for me, I spend probably around 80% of my time in the clinic facing clients.
Now, about 18 months ago, we talked about the weight management service that you run from Remedy Health, focusing specifically on GLP-1 receptor agonists. Since then, I think it's fair to say there's been an explosion in the use of these products and interest in these products. And news media and internet are awash with articles about them. So it seems like a good time to take stock. And my first question then is, have the GLP-1 receptor agonists lived up to their promise, and indeed the hype? And are they a safe, easy, and convenient way to lose weight?
So our experience over the last 12 to 18 months has been that this really is the first time we've had anything that's effective for weight loss. And from that point of view, they truly are a game changer in the way to support people to get to a healthy weight. And by doing so, are making a big difference to health outcomes. And I don't think we should forget that. With respect to a safe, effective way of helping people to lose weight, certainly the experience has been very positive so far. Out of around 70 patients that I'm currently supporting, we've possibly had 3 that have discontinued use due to side effects. But otherwise, they seem to be pretty well tolerated. We take great care in supporting people for safe, effective weight loss. And of course, it's not just about the injection alone, but we'll be talking about that a little bit later.
Since we last spoke, tirzepatide, Manjaro, has been launched. Could you just briefly explain the differences between the two products, semaglutide and tirzepatide?
Yes, of course. So semaglutide is a GLP-1 analog, and tirzepatide is also a GLP-1 analog. It's a dual agonist, which means it has a secondary effect, which is that it is a glucose-dependent insulotropic polypeptide, but we thankfully abbreviate that to GIP. So it works on those receptors. So if we focus first on the GLP-1 effect, these medications inhibit the release of glucagon. That's a hormone that raises blood sugar and promotes glucose production in the liver. So by lowering glucagon levels, we get a more stable blood sugar, and they also slow the rate at which food leaves the stomach and enters the intestines. So that improves how full we feel. So our satiety levels go up after eating and reduces the sudden increase in blood glucose after we've eaten. So that postprandial blood glucose rise. We also see that the GLP-1 receptor in the brain are activated, and that reduces hunger and food intake. And there is some research being undertaken at the moment because it seems to have an effect on addiction. And certainly I've had some clients who've given up smoking, reduced alcohol intake significantly, as well as some addictive behaviors such as gambling as a result of taking these medications. So that's work in progress to see what the evidence will generate around that. But the effect in the brain seems to contribute to weight loss because it reduces that noise that we were talking about, the food noise, but also stops people eating beyond being full. So there seems to be an effect on the beta cells in the pancreas as well, and slows the progression of type 2 diabetes. And I've certainly seen where we've monitored people's HbA1c, a drop in HbA1c from pre-diabetes to normal levels, which is great news. Now, the GIP effect is in addition to GLP, and it seems to enhance insulin secretion, particularly during meals, and complements the GLP-1 effect. So you see a synergistic effect between the two agonist actions. So it also seems to improve insulin sensitivity. And of course, type 2 diabetes and metabolic disease is all about insulin resistance. And that includes sensitivity in muscles and fat. So it seems to also, with this synergy with GLP-1, reduce hunger and improve energy balance. I mean, the bottom line is we don't know fully how these drugs affect. We certainly don't know how they improve cardiovascular outcomes if we talk about semaglutide specifically. But we do know that they have, from the clinical outcomes, a positive effect on HbA1c, cardiovascular outcomes, and on weight.
As we know, the less common side effects of any medicine only become apparent after wide usage of the product. Can you say anything more now about the side effects of GLP-1 receptor agonists in practice?
As we know, the GLP-1 receptor analogues, they work by delaying gastric emptying as well as causing satiety and reducing appetite. So having some direct effects, it seems, within the brain. So the most common side effects and the ones that we counsel people about, so they're prepared for them, are related to that delayed gastric emptying. So they tend to be things like reflux, nausea, rarely vomiting. It's very rare for somebody to have vomiting in my experience, and constipation. Diarrhea can happen in some patients. It's sort of counterintuitive to the delayed gastric emptying, but it can happen and it is listed as a common side effect. Those are the main issues. Some people can feel tired. That's been a rare side effect in my clinical experience. But we can support people. And in fact, we do give people a lot of support around being prepared for those side effects. So, for example, having some antacid available to deal with reflux, having something for such as loperamide available if their gut is loose, fiber, the osmotic and fiber laxatives, making sure people drink plenty of water. And one of the main reasons people have gastric issues is if they overdo it. So if they overindulge, if they eat something that's particularly rich, or if they put too much into their stomach and their stomach catches up with how much is in their tummy because of the delayed gastric emptying, then that's when they can experience difficulties. So they quickly learn what they can and cannot eat and how much they should eat.
And can you say anything about the more serious side effects that have occasionally made headlines in the mainstream media?
When any drug is new to market, whatever it is for, then we are, as prescribers and and as pharmacists, acutely aware of reporting side effects and being mindful that any drug is about risk versus benefit. And this slightly leads into the conversation we're going to have about the General Pharmaceutical Council's revised guidance for online prescribing. When I'm sat with a patient face to face in the clinic, I'm able to check their BMI, their weight, go through all comorbidities, look at any other medication they might be in, and together we come up with a prescribing decision based on the benefits and the significant benefits of losing weight and becoming a healthy weight versus the risks that may or may not be associated with that particular medication. So it is a really important discussion to be had. I cannot say whether any particular situation is directly related to a drug or not. None of us can until it's been fully investigated. But I think it's an important lesson for all of us to make sure that we're safely prescribing as much as we can, that we involve the individual in the decision making, and that the risks are weighed up against the benefits.
Well, that takes us on quite nicely. How should people obtain supplies of GLP-1 receptor agonists?
Well, Christine, I'm always going to say see a healthcare professional face to face, because this is so much more than prescribing. In a consultation here at Remedy Health, we spend 45 minutes with an individual going through their health history, any comorbidities, any allergies, any medications they might be on, a full clinical history, as well as probing and understanding their relationship with food, the psychology. Are they an emotional eater? Do they have problems with hunger? A whole host of different questions. We explore lifestyle, the kinds of foods that they're eating. And our goal is always to seek a long-term healthy weight. And at some stage, they will come off the medication. So how do you make sure that you're getting long-term behavioral change? So I am trained in behavioral change techniques as well as motivational interviewing. So face-to-face, an individual gets the right kind of intervention for them. And we can make a choice as well, whether it should be semaglutide or tirzepatide, based on that individual's profile. We go through side effects, risks, benefits. And then we're able to supply the medication directly in the appointment whilst they're in the clinic. And in fact, we often supervise the administration of their first dose so that we can go through injection technique, give them the confidence that they're doing it properly. And we, of course, use all the main supply chain routes, so our major wholesalers. So these drugs are not counterfeits, they are sourced through the manufacturer, and they have the appropriate supply chain securities. So I think online, particularly if it's not from a registered online pharmacy, and why would the public know any different, is asking for trouble. And we do know from the MHRA that there have been some hospitalizations from people who have administered drug that isn't as it says it is, and it's counterfeit.
I'm wondering if you are eligible for supply via the National Health Service, isn't that the right way to go?
So from a license perspective, eligibility is from a BMI of 30 or a BMI of 27 if there's at least one other comorbidity that qualifies. So for example, high blood pressure, high cholesterol, pre-diabetes, etc. However, that is different to how services might be commissioned by the NHS in your local area. So I have had conversations with clients who've accessed this service in line with the licensed recommendations privately, and they would be eligible potentially under the NHS. However, they've either not been heavy enough because the threshold for entering the NHS has been higher than the licensed BMI, so 35 plus, depending on resources in an area. If they do meet the criteria locally, what they're finding is there can be a significant waiting list and delay in having medication prescribed. So the soonest I've heard of somebody being prescribed it is a possibility of 12 to 13 weeks. The longest is a waiting list of over a year. Furthermore, they may or may not be offered the choice of either product. It depends on how it's being commissioned. So in one particular instance, a client that's come to us felt, and together we felt actually, that tirzepatide was be a better choice. He's got pre-diabetes. And whilst both drugs are effective, we felt that tirzepatide would be more effective for this individual, but that wasn't on offer to him via the NHS, and he had a significant waiting time before being put on it. So to answer your question, if somebody is heavy enough and meets the criteria, they should always have a conversation with their GP. But having made a decision to go down this route and to make a change and to adjust their weight for their health, then sometimes time is of the essence and you want to get cracking.
And just following on there, what kind of support do you offer in addition to the drug?
From our point of view, we feel that early engagement is important. And we see people every 4 weeks. And that 4-week checkup allows us to weigh that patient, for them to have the accountability, for us to check for side effects and whether it's appropriate to escalate the dose or not, because we obviously are going through a titration in the first few months, and to check efficacy. So sometimes we need to make a switch for patients between one drug or another. That might be due to side effects or due to effectiveness. Sometimes we need to keep people at the same dose, and that's perfectly effective for them. And we'll talk about those experiences in a moment. But I think certainly I can't comment on other private providers' service, but what I can say is I believe we're offering something that has shown effectiveness. We've had significant weight loss across the board, and is working for individuals.
I've seen criticism recently from the NPA, I believe, that some private prescribing services have led to seriously underweight people actually being prescribed GLP-1 receptor agonists. How is this even possible?
Well, I can only imagine that that's as a result of prescribing being done by questionnaire, which is why the GPHC have issued their guidance. So a lot of online providers have had a service where the patient fills in the questionnaire and uploads a photograph of themselves. That hasn't been verified to date as being current, and therefore people have accessed medication essentially by lying and perhaps not understanding the implication of that. And the prescribing is made on that basis. Now, that can't happen in a face-to-face situation, because people jump on the scales and we measure their height and we do their waist, calculate their BMI, etc. So that is one of the drivers behind the change in GPHC guidance for online prescribing of these drugs. I think it's an important intervention to have made. So in future, that current weight has got to be verified, and a face-to-face online consultation has got to take place. And I think that's really good news for the safe prescribing of this medication. I spoke to a client this morning whose friend had uploaded a photograph from 6 months previously in order to confirm her BMI was higher than it actually was. And so I think it's any of these process, people will find a loophole if they want to. But for our part, I can state that we are able to verify the weight because it's happening in my consultation room.
I've also seen articles suggesting that fake drugs might be supplied, and you mentioned this earlier on today. If someone is looking for a supply of these drugs on the internet, what tips can you offer to make sure that they don't waste their money or buy something that might harm them?
It's like the supply of any medicine. If you are choosing to go online, then you must make sure that that particular pharmacy that you're accessing the service through is registered with the General Pharmaceutical Council, and they will have to have a logo with their GPHC number on their website, and you can pop that number into the GPHC register to check that everything matches. So that would be my first tip. If you can, I would suggest contacting that online provider directly to make sure that you are able to further verify their authenticity. And you may also want to check that where their supply chain comes, where their supply of medication comes from. I think people also need to be very mindful of you get what you pay for. And if something is particularly cheap, then that's got to raise some alarm bells. So I think, it's if you're going to offer a high quality, safe, secure service, then there is a price associated with that. And ultimately, you are paying for your health.
Now I'd like to focus on what we have learned over the past 12 to 18 months. And my first question is, do you need to take GLP-1 receptor agonists forever, or can you just use them to get down to a desirable weight and then stop?
I think it's a really interesting question and one that I discussed very early on in the journey with my clients. We discuss as early as that first consultation what their exit strategy is and how we might manage them coming off the medication. And it's very interesting. There is nothing in either summary of product characteristics about coming off the drugs. It's all about going on them and how you titrate people up. So as clinicians, we are, dare I say it, making it up in terms of what coming off the medication looks like. And certainly we can look to some of the experience in America where they've had these drugs available for longer. So I think there are a number of different ways that we can consider people coming off them, which would be our ultimate goal at the moment based on the data we've got. I'll come back to that point. The first is that people literally reach their goal weight, and they stop the medication. Over that period, we are working with people to change the way they eat, how they look at food, how they recognize the triggers for eating, and the types of food that they're eating. So essentially, we're looking for long-term behavioral change. But the reality, Christine, is that our body is biologically designed to want to gain the weight that we've lost. It's not a myth. The reality is that our body will drop its metabolic rate and it will also increase the hunger hormones in response to us dropping our weight. So by coming off the drug quickly, you are in danger of fighting the biology of, to want to gain that weight. So that's one strategy, to come off quickly. And we've had a couple of patients that have done that. Often for things like a cost consideration. They've reached their goal rate, they've got goal weight, they've got to where they wanted to get to, and they're happy that they're not paying for treatment going forward. But in the 2 or 3 examples that I've got, they have regained some weight. So before regaining it all, they've come back and said, I found that really quite difficult. So can I go back on perhaps a lower dose to give me a bit of help to maintain my weight for a longer period, and I'll come off it slower. So the second strategy for coming off these drugs is to do what those initial clients have done, which is come off the medication when you reach your goal weight, but then to have a tolerance of what your weight gain might be before coming back on it. So that's another option. So perhaps look to, if I gain half a stone or my BMI gets to this, then I'm going to go back on the medication. The other option is to come down the doses just as you went up them. So let's, for example, say that you've taken yourself up to 2.4 semaglutide, Wegovy, in 5 steps, then you come down it in 5 steps. So you're following, once you've reached goal weight, you go down to 1.7 for 4 weeks, then you go down to 1 for 4 weeks, then you go down to 0.5 for 4 weeks, and then finally 0.25 before coming off. That strategy seems to be much more beneficial in getting the body adapting to a lower amount of semaglutide in the system, or tirzepatide, and allowing people to adapt to the behavioral changes that we've talked about, and for perhaps their hunger hormones not to sort of kick in quite so quickly. Nothing in the literature or the guidelines around that, Christine. That is, there is nothing out there at all. I think as clinicians, we are paving the way in terms of our experience, but certainly from my clinical experience, that seems to be the best route forward, and not go cold turkey.
So do some people actually need to take these drugs forever?
To answer your question, are these drugs for life? I think there's increasing debate, because we know, for example, the SELECT trial has shown that semaglutide is a cardiovascular drug, as well as being a diabetes drug and a weight management drug. In other words, you get better cardiovascular outcomes defined as reduced stroke and heart attacks in people that are overweight and obese, irrespective of their weight loss. So it isn't just a weight loss effect that's improving their cardiovascular outcomes. And that is very exciting indeed for the cardiologists who feel quite strongly, and it does have a license for this, that it can be used for the prevention of cardiovascular events in people who have a BMI above 27. So this leads us to a possibility of people being on these drugs long term.
I have also seen articles suggesting that we are facing, and I quote, a future tsunami of sarcopaenia and osteoporosis as a result of widespread use of GLP-1 receptor agonists. Do you have any comments?
I do, Christine. I think it's important for us as clinicians to remember that we don't yet have long-term data. And by that, I mean 15, 20 plus years data of the use of this medication. Certainly, the signs are incredibly positive around the benefits that these medications are having. You know, weight loss is now the single most important contributor to death. And we have to remember that it has a huge impact on mortality and morbidity. And it is going to cost countries an absolute fortune in healthcare. We're only tipping the iceberg, but we know the impact on the UK is massive, into the billions of pounds a year. But from a safety perspective, we always need to be mindful that we don't yet know the long-term impact of these drugs. So we have to proceed with caution. Now, the comment around sarcopenia and osteoporosis is an important one because they're linked to muscle loss and bone density loss, the latter being connected to low weight. So, of course, if you've got people who are not being monitored correctly, who are taking it to be underweight, then you are going to lead to those kind of issues. Hence the need for us to be responsible in our prescribing and to make sure that the GPHC guidelines are implemented. With respect to sarcopenia, it's a really important one. With any rapid weight loss, wherever it comes from, we can lose muscle rather than fat. So alongside our guidelines with people and the counselling that we give, it's important to maintain strength training throughout the use of these medications to keep your muscle mass up. We also extensively counsel people to eat protein, food rich in protein, because these drugs can have such a significant impact on appetite that people only want to eat maybe one meal a day, and even then it's a small meal. So if that's the case, then you need to make sure that the food that you're eating in that one meal a day is high in nourishment, that it is rich in protein, that it is giving you the optimum nutrition. If somebody is having one meal a day and it's a few oat cakes with jam, that's not going to give them the nourishment that they need. So it's important that people understand the science that underpins their weight loss, hence the need to have face-to-face clinician patient dialogue and the contact and the support that's important during this process.
Now, you have been prescribing these drugs for 18 months or so and have some 70 patients under your care. What have been the key learning points as you have developed your clinical experience of prescribing this class of medicines?
There, of course, have been many learning points, and the ones that come immediately to mind are that no one patient is the same. We don't have any head-to-head clinical data around the side effects of one drug versus another. So, of course, in the last 12 months, we've had tirzepatide, Mounjaro, come on the market, which is given a choice. So when in a consultation with a patient, how do you make a decision about whether it should be semaglutide or tirzepatide that we go forward with? And so the learning over the course of the last 12 months has been very, very interesting. Certainly my experience and some of the data would support that semaglutide as a GLP-1 analog only has a greater effect on satiety and appetite and cravings than perhaps the combined GLP-1 analog that tirzepatide is with glucose-dependent insulotropic polypeptide, which is GIP. However, tirzepatide, we know from the clinical trials, has a greater effect on the way insulin works, and therefore is particularly good for people that have signs of prediabetes, have that metabolic kind of belly, and have perhaps been overweight for longer. So it can be particularly effective. In my clinical experience, I don't have any trial work to support that, other than tirzepatide does, it would seem, give better weight loss based on the trial results. So we know over a 12-month period, the average weight loss on semaglutide is around 15% of body weight. Tirzepatide is around 21-22% of body weight. So in my own practice, I would say I've seen greater weight loss with tirzepatide, but it's not always the perfect choice for an individual.
That's very useful to know. Is there a similar pattern with side effects and tolerability?
We have had situations where somebody has had side effects that they can't tolerate on one medication, but we switch them over to the other and they're absolutely fine. And it can work both ways. So there's no one drug that has, it would seem, more side effects than another. If I was going to make an anecdotal observation, I would say the side effects are slightly lower on semaglutide, but again, no clinical data to support that. And I have quizzed both companies, but neither have the data against the other, which you would expect. It's just against placebo.
Well, if responses are so individual, is the dose the same for everyone?
Clinical experience would absolutely tell me that no one patient is the same. When we're escalating for efficacy over the different drugs, very interestingly, many patients don't need to go up to the full dose. So just to remind people that semaglutide has 5 doses as Wegovy, licensed for weight loss. It's 0.25, 0.5, 1 milligram, 1.7 milligram, and then the top dose is 2.4 milligram. And the idea is to titrate people every 4 weeks up to the 2.4 milligram, the effective clinical dose. However, in practice, I've got individuals who are very happy stopping at perhaps 0.5 milligram or 1 milligram. They're getting good efficacy, they're tolerating the drug well, and there is no clinical reason why we should escalate beyond that. With tirzepatide or Manjaro, we have 6 doses. We have 2.5, 5 milligram, 7.5 milligram, 10 milligram, 12.5, and 15 milligrams. The majority of my clients are either on 5 milligram or 7.5 milligrams, and that's giving them 3 to 4 kilograms of weight loss a month. It's well tolerated, and they haven't needed to go to the top doses. However, I have had clients that have had very little efficacy, even at 10 milligrams, and have had to go all the way up to 15 milligrams. But it does seem that there's a point where efficacy clicks in, and it can be different for different clients. So I think that's been a really important learn.
Is it easy to switch from the one drug to the other in practice?
I did mention earlier that sometimes we need to switch patients from one drug to another. And here, this is quite a difficult decision for a clinician. And I had a particular case where my client, who has a very high BMI at starting, over 60, was going through, we started her before tirzepatide was available, and we got up to 2.4 milligram, but we weren't getting really the impact of the medication that we needed. She'd lost a stone and a half, but wasn't doing as well over that 6-month period that we would have, either she or we would have liked to have seen. And she was still feeling hungry. So we discussed changing her to tirzepatide, which had been then licensed and made available. And of course, the guidance is that we go back to the beginning. It's a bit like a game of snakes and ladders. So you have to go back down to, according to the license, Manjaro 2.5. This poor client fell off a cliff with respect to her weight loss journey, and it took us another 3 months to regroup. And in fact, she lost faith in the drug and requested going back on semaglutide. And so in that particular instance, it was a lesson hard learned as a clinician. And actually, we've been more pragmatic since in terms of switching people over. And, that's when the decision as a clinician becomes an off-label one, where you might make a decision, if a drug has been particularly well tolerated, to go in at a higher entry level in the alternative. It's not an easy decision to make. A risk assessment is made. But it was a hard-learned lesson in terms of the psychological impact that something like that can have on a patient, because we're following to the letter the requirements in the SPC. So we have a little bit more experience around switching. I hope in the future we're going to have some guidelines around doing that, which are more formal and pull together clinicians' experience across the board.
Mm-hmm. And just a thought, is there such a thing as a non-responder?
I would say there are some clients, and reviewing what I can out there, who just don't respond at the top doses of either drug. Maybe a little bit, but not, whether that's a pharmacogenomic issue, whether it's based on insulin resistance. And I think in that particular instance, certainly I've had one patient in that particular category, a referral to an endocrinologist, and perhaps looking at adding in one of the other diabetes drugs in particular, which seems to be able to enhance the response. And of course, we've got the excitement of new drugs coming on in the market in the future, which will have other properties. So those have been my main learns from a clinical point of view. I think reinforcing everything I said earlier about the importance of behavioral change, of helping people around psychologically adapting to their new weight, overcoming body dysmorphia, overcoming fear of eating properly again. All of that requires a very careful management and counselling to support people on their journey, because we are all very different.
What advice would you give to someone starting weight loss treatment to achieve the best results? I know that Remedy Health has a leaflet about this for patients, but perhaps you could just talk us through it.
The first thing is what to expect when starting your weight loss injection. So we explain the science and how it's going to work, so people's expectations are clear. We guide them through that first injection, and we talk through the possible side effects. We might even, if somebody's prone to constipation and that's being clear in their pre-consultation, then we might give them something, a laxative to take with them. Or if they're prone to gastric reflux, we might give them some Gaviscon or something similar to take too. We talk about the common side effects, therefore. We counsel them to watch out for more serious side effects, for example, pancreatitis, although the jury's still out around the real risk of that. We talk about appetite suppression and when that might kick in. So that's important, because for some people it might be immediate within a day or so. For others, it might be more cumulative in terms of the effect it has. And for some, they might need to go up a dose or two before they notice a difference. So I think it's important that people understand that in terms of their expectations. I make it very clear that this doesn't burn calories. So the only way that you're going to lose weight is to be in calorie deficit. So that's increasing activity and reducing what you eat. So if you continue to drive through and push through all the cues that your body's giving you, that you're now full and that you're not hungry, then you will not lose weight. That's the simple message. So We say to people, take time for the injection to work, be patient, but to also put in strategies for weight loss alongside it. This gives you some additional discipline and willpower. It's not going to do the legwork for you. We also recommend that people find the foods that are going to be safe for them to eat. A wide breadth of food, protein, reduce the amount of carbohydrates that they're eating, lots of fruit and vegetables, particularly vegetables, to increase the nourishment that they're getting, to avoid high fat foods, high sugar foods, not to drink fizzy drinks, all the kind of tips and techniques that you would put in place for a weight management diet. Important to maintain muscle through physical activity.
Just a thought. Do we eat too much?
I think as well, we've all got used to eating too much. Our portion sizes are big. We eat more frequently than we should do. And we've almost set in our mind, well, if I don't eat breakfast, then I'm going to feel lightheaded by lunchtime. The reality is we can eat a lot less than we actually put into our bodies. And actually, the feedback that I've had from clients is I had no idea that I could have so much energy on eating so little. So I think that's an important message, that actually we probably feel quite tired and sluggish because of the amount of food that we're eating and when we're eating and the types of food that we're eating. So that's an important message. A lot of clients feedback that these drugs reduce food noise. What do I mean by that? Well, this constant chitter chatter in our heads. Where's the next meal? Is it time for breakfast yet? Should I have a snack? Where's my next cappuccino? What have I got in the fridge? When do I need to go to the supermarket? What am I going to eat tonight? Are we going out tonight? Are we going out for pizza? Or whatever it might be, the chitter chatter in our heads about food, which seems to escalate if we go on a diet. Suddenly food becomes the primary focus and what we can't have. What these medicines seem to do is just dial that down or switch it off completely, to the point where people will say, blimey, I got to 3 o'clock in the afternoon and I realized I hadn't eaten anything yet. So it's important, therefore, as I mentioned earlier, that if people are on these medications, that they need to really focus on nourishment, nutrition, and to make sure they're eating the right things. They might need to take some additional supplements, particularly, of course, at this time of year, vitamin D, and to make sure that their protein levels are high. And of course, protein has high satiety value. So if you get into the habit of eating more protein, not only does that help with your muscle mass, but it helps long term in terms of changing your food habits away from carbs into protein, which in its own right keeps you fuller for longer. I would also say be patient. I don't know how that individual in front of me is going to respond to the weight loss medication. I had a young client in this morning and she's lost over 2 stone in 3 months. She feels amazing. She's got loads of energy and she's doing really well. I've had another client who's taken 3 months to lose half a stone. So we're all different.
And standing back and thinking about weight loss services, is it a worthwhile service to offer?
But it is an incredibly joyous service to offer because it's creating results and people feel in control and they feel so much better. But importantly, we're reducing the risk of type 2 diabetes, of cardiovascular disease. For every single kilogram of weight lost, individuals will have 4 kilograms of weight reduced through their joints. So we know that it's going to reduce pressure on knees, for example, has an effect on a whole host of body systems as well as people's mental health. So in my consultation room, which we're not in at the moment, otherwise I'd get them out, I have sets of weights and I have a big lardy piece of 5 kilogram fat, which people see when they've lost 5 kilos, then they know how much they've lost. And today I was able to give my client the equivalent of her 15 kilograms of weight lost. Neither of us could lift it. We were really struggling. So it really helps to understand what impact that weight loss is having so that you can feel more motivated to keep it off long term.
And now my last question. The service that you offer is private, paid for by the patient, separate from the NHS. Does this present any problems?
On that note, I just want to say something about the visibility of private services. to the NHS. So if somebody is prescribed a medication privately, it's not necessarily automatic that that then becomes visible to their GP. We don't have any read access to the summary care records, for example. We don't have read or write access to the summary care records. So the GPHC guidance that's been published this week has now put weight management drugs and injections into high risk category. I would say prescribed correctly, they're not high risk drugs. However, the reason for doing this is to ensure that the default is that the prescriber informs the patient's GP via consent from that patient that they're on these medications. I think that's really important, that GPs have visibility. A lot of patients might tell their GP anyway, but it's quite a sensitive area. And so some people don't want anyone to know. They hide it from their family. And the reason for that is that there may be some interactions. That individual might get pregnant. There's a whole host of different issues that other providers of that patient's health, and arguably the GP as the lead provider of that patient's health, should have full knowledge of. And just to give you one very small example, I've got a patient, and there must be many out there, who is planning elective surgery. So she asked for my advice around what she should do about her GLP-1 analog going into surgery. Now, interestingly, MHRA last week published a bulletin around the use of anaesthesia when people are on GLP-1s and the risk of pulmonary aspiration. Because if we're delaying stomach emptying, then the usual fasting timelines may not be sufficient to make for safe anesthesia. And in fact, a colleague of mine is an anaesthetist, and we've been having a very spirited debate over the last week or so. And at the end of the day, people should continue with their medication unless they're advised otherwise, but inform their anaesthetist that they are on these drugs. That's great if you're going into elective surgery. However, if you're in an emergency situation and you need an anaesthetic, then it's always useful for that to be somewhere on your record so that people can make the right decisions about your care.
Deborah Evans, thank you very much for talking to us about this fascinating topic. That really has been tremendously interesting and thought-provoking. For more information about Deborah Evans' work at Remedy Health, please visit the website using the links in the description, and be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.